There's going to be a lot that we cover today, mostly me thinking about, what can I do in 1 hour that can help set you up for success for the rest of the year and for all the years to come. So we've covered a fair amount of content already in part one. Really, our goal to help clinics that are transitioning from 2D to 3D or that are planning for that transition, but also a really good opportunity for clinics already doing 3D to have a chance to see and learn as a team. And learning these best practices and everyone being on the same page is so helpful for your clinic. Understanding how even do we begin a program with accepting and commissioning our machines, thinking about what can we do and making plans forward as a team, and then understanding the workflow that the patient is going to go through from start to finish, beginning with simulation, getting that CT scan, figuring out how you're going to do the plan and writing those instructions out clearly. And then with this, everything is going to begin with how the contours are. And the contours are going to be on that CT scan. And if the contours are good, then there's a chance for the planning to be good. If the contours are bad, then no matter how the planning is, the plan will be bad. So you need good contours to have a good plan. And if you have a bad plan, then no matter how good your setup is, the treatment won't be good. So you need good contours, then you need good plan, and then you need good setup and good treatment. So are you guys ready for part two? In part two, we're going to dive into contouring, planning, QA, making sure the plan is good, and then tips for during treatment while the patient's on the table, things that can help you make sure that you're delivering your 3D treatment accurately. So we're going to continue our schedule of once a week on these Saturdays. Session 17 is going to be on a Sunday, so just so you can plan ahead. That's the only day that's different. And today we're going to cover introduction to contouring and to ProKnow, how this will connect to treatment planning, and the importance of quality, which I've alluded to, and it's going to help prepare you for success with every treatment. So to begin, which of the following are you familiar with? Meaning you could describe what it is to a friend. So this is our first Zoom poll question of the year. And Michael, do you see the Zoom poll?
Yes, I just launched it now.
And I think this lets you choose multiple options. So if you've heard of more than one of them, you can select more than one. Okay, this is so interesting. Maybe we'll give 6 more seconds. We have 85 participants who have filled it out. Let's keep going. Okay, very good. I'm going to end the poll and let's share these results. So can you guys see this on your screen? So it looks like about 60% of you have heard of econtour.org. 44% of you have heard of the Quantec guidelines. And then 20% have heard of RCC's self-learning online resources. That's great. And then some other resources which may not be as well known. There's the Energy Oncology Contouring Atlases, ProKnow Systems Quality Contouring, which we'll show today, and RADONC tables. Okay, excellent. So ProKnow. So there are two things with ProKnow. The first thing is something called ProKnow Systems. And this is set up and ready for you to use. So here are the URLs, and I'll put these in the chat. And this is a good session if you have your computer, so you can save all of these URLs, but I'll also be giving these slides at the end of the presentation too, so you can have them. So these are two different modules on ProKnow Systems, one that helps you practice your contouring and get feedback right away. The other is for treatment planning. So for those who do treatment planning, it lets you download a case, plan it on your own system, and then upload it. And then you will get graded based on how good the plan is. And you can compare how your performance is to other people, and you can keep trying until you make it better and better. So these are really good resources, especially if you're hungry to practice contouring, hungry to practice treatment planning. And just to give you a very quick peek at what this looks like. So this is the pronosystems.com/contouring. You have to make an account and it should be free. And then once you're in contouring accuracy, now you can see all of these different structures, which maybe you haven't done before, maybe you have done, but you want to make sure you can do it well. It lets you click into it. So this is for the right optic nerve. It has some documents with instructions and some guides. And then when you're ready to go, you can launch the contouring. And then now you have your simulation scan. You can scroll through and we want to contour the right optic nerve. And then you follow the instructions and then it lets you contour. So if I like to use the paint, that's what I'm used to doing. And then maybe I'll make this just a little bit smaller diameter. And then I'm going to do the right optic nerve, and I actually have a little video guide for this too, which I'll share. But you do it one slice at a time, and I'm going to do this quickly. Actually, I'm going to see. Let's just see how this goes. So I have something I've drawn, and I can click I'm finished, and then generate score. And okay, I got an 81 out of 100. And then here it shows, okay, so green was good. Red was extra that I drew, and blue is part of it. It says I was missing. So this is helpful. You get good feedback, and then you can review the scan, you can practice again, and that is what the contour accuracy is like. Okay, great. So the second thing is called ProKnow DS. And Rayos Contra Cancer is thankful to partner with ProKnow to make a platform like this available for everything that we do in our global health education and training work. And so you may have gotten that Google form in your email with instructions for expressing your interest in this. And after this, once the form closes on Monday, we're going to see who filled it out and work on making accounts for each of you to be able to log on and practice contouring a full case or practice downloading and sharing the case with us in case you want additional feedback. And so there's going to be one case for contouring and one case for treatment planning. And what this is going to look like once you log in, and we'll have these instructions, is you will be able to see kind of a library of cases. Now we're just going to start with one example, and then you can download it and then plan it and then upload it. And so this was from a prior year when we did this, and we had a few submissions. So each of these other ones here are cases of it our participants submitted. And so this is an example one. And what are we seeing here? Well, this is a plan and it has all the elements that we've talked about. It has the CT simulation scan. It has contours, and you can see these contours are made one at a time. That's the whole body, bowel, bladder, rectum, and then some of our other targets like the gross tumor and the CTV, where there's risk of microscopic spread of disease, and the PTV margin, which goes around all of that and accounts for day-to-day uncertainty. the day-to-day expected uncertainty. And then we have the plan. So those who do the planning, you're probably smiling. You're like, this is the part that I do. And they ultimately will be making the dose distribution. In this case, this plan was 4 different beams. Looks like a beam energy of 1 MV was used, but often we'll see a beam energy of 6 MV or 10 MV. And then each of these different colors represents a different dose line. So everything that's red here was getting 48.6. Everything that's in this yellow cloud was getting 36.6 gray. And then you can customize these dose lines so you have it showing the dose level that you want. So if I wanted to see 16 gray, could change it. Okay, and then there will be a dose volume histogram too. And you may remember we had a session where we had to practice interpreting a dose volume histogram, and these can be tricky, but I recommend if you're curious about a certain structure to just turn off the other lines and then look at one line at a time based on what you want to see. It can be kind of hard to interpret all of this at once. Even the experts need to look at one line at a time. Okay, so just a refresher, when contouring, we have the gross tumor volume, the GTV, the clinical targeting volume, which is the CTV, the planning tumor volume, which is the PTV. Any questions about these terms? Okay. We have organs at risk, or OARs. And these are the normal tissues that are at risk of receiving high dose and being close to the tumor. So the kidney is an example of an organ at risk, brain, brainstem, optic nerve, optic chiasm, spinal cord. So depending on the different part of the body, there will be different OARs. And I've kind of listed many of the OARs here to make sure that you're thinking about. Now, PRV, this is a topic which we may not have spent a lot of time on, but this is a little bit like a PTV for an OAR. So, okay, for PTV, it's my small variations in patient positioning or expected mechanical inaccuracies, which basically create a little extra margin around my CTV that I want to make sure I cover. PRV is related to concern about the variability in organ position. It's not always used, but there are some OARs that tend to fidget and wiggle. So bowel is a good example. If I took a picture of someone's bowel every day, it's going to look a little different. It doesn't really stay in the same place. So there's some degree of expected movement for some OARs. And when using a very high dose per fraction, such as is with SBRT, these are the times when we usually will consider using a PRV, or if we're using a very high dose and we want to be very careful close to structures like optic nerve or spinal cord, we may also use a PRV. And yeah, you may be a little confused, like spinal cord. I thought the spinal cord just stays completely still. Well, even the spinal cord can wiggle a little bit, 1 or 2 millimeters.
We had a couple of questions in the chat from the last session, or from the last question area. So first was any open software that can be used to learn how to perform contouring. So one thing that we're doing in this session is sharing about those resources. So ProKnow that you can sign up for is a really excellent resource to be able to practice contouring, and then we'll go over eContour and other open platforms that can be used. And then Ben, I'll give this one to you. Where does the ITV come in the expansions you were discussing?
Oh, good. ITV is usually when we're doing a treatment with a high dose per fraction where we want to be really careful, and there's going to be big movement related to respiration. So lung tumors or upper GI tumors. And the way to determine an ITV is or I guess the way that centers are commonly determining ITV these days is taking a 4D CT scan. And what does 4D mean? It means in addition to the 3D, you now add time as an extra dimension. And while someone is breathing, you get a scan that's capturing all the phases of respiration as it goes down, up, down. And with that four-dimensional CT scan, you'll be able to see your tumor in one phase, in another phase, in another phase, and then how it goes down. And what the ITV is essentially making sure that you're capturing the full range of movement that tumor is happening. So a little bit more advanced, not used to my knowledge that much when we're doing 3D cases, but certainly with more advanced treatment techniques. Good question. Okay. So the whole reason that we contour is because you achieve what you measure. And if you don't measure what you're doing, how can you even tell if you're doing a good job or if you're improving? So when we're looking at the DVH and looking at the dose, it's only going to show stuff that you contoured. And if you didn't draw it, you won't see it. So rule number one, you always have to contour all your targets. And this means sometimes you have the main tumor, but sometimes you also have lymph nodes that are involved. And you can't just ignore those big tumor balls of lymph nodes. You have to also contour them. Gross disease is very important to get all of the dose. And a lot of times the gross disease gets a higher dose compared to your subclinical disease. Furthermore, you don't just draw them, but you have to really draw your targets correctly. Or else, let's say that let's say that this is what my tumor looks like. You know, big, ugly cancer. We want to cure it. If I draw a target that looks like this, I need to get my eyes checked. But now my treatment planner, they're giving instructions, hey, make sure that I cover the target. So they're going to work on giving a dose that's covering my target, you know. And what do we see? So this area is getting the amount of dose that's needed here in the middle. This area is not getting enough dose. So even though maybe it's getting some dose, if it's not getting all the dose it needs, that cancer is not going to be controlled. And then after treatment, a couple months later, this tumor is going to start growing and growing, and then the patient's going to have a recurrence. And then this is going to be really hard to deal with because you just gave a treatment next to it. And now you have this hard situation where do I give re-radiation? Do I do surgery? What do I do? Or can you do anything? So you really want to avoid that. What else is bad here? Well, since I have this extra area that's getting high dose, this is an area potentially where you could have more toxicity. And let's say you had your bowel, like what your OAR here. Now your uh, now your OAR is getting a lot of high dose there, and that could be dangerous. So it's a double-edged sword. And the second rule is contouring OARs. You must contour any OARs that are close to your target. What I recommend is if there's an axial slice, you have your target here, and then this is an axial slice for a person. Any OAR that you see on the slice where you have your target, you should make sure that that OAR is contoured. That's best practice. In other words, if I were to look at a sagittal view, sorry, this is a weird patient, and I have my tumor, and then I have my, let's say, my CTV, and I'm contouring some lymph nodes. And this is a sagittal view. So remember, sort of a side view of a person. I want to make sure I contour all of my OARs that are between here and here. Because all of this area is going to be getting beams because the beams go perpendicular to the patient or they're coplanar. And all of this area could be getting dose that I want to make sure I measure. Now, human judgment can be inconsistent and there can be sort of forgetfulness and there can be some mistakes. So what I really recommend is that for each common scenario, like, okay, cervical cancer case or prostate cancer case or breast cancer case, that it's already specified what OARs need to be contoured and saying what goals need to be accomplished for those OARs. So this is called a template planning document. And just to give an example of a template planning document, I can show you one that we've been using at my center. This is for whole breast 5-fraction treatment, sort of per the fast forward protocol. And it looks something like this. So this is a template. It can be applied to each patient, and you should write down, patient's name, date, some things like that. But this is going to be treating the left breast with 3D conformal radiation with photons, and it gives the sort of total dose that I'm going to be giving and how many fractions. And then I have my OARs already listed. And if the planner sees that one of these isn't contoured, they're going to say, doctor, like one of the OARs is missing. And then the doctor needs to make sure that they do that. One, all the OARs are contoured, the planner knows how to plan it. And this is a practice which we are sort of starting to adopt. It's been really helpful. For some structures, you want to tell them like, okay, absolutely, we need to meet this required objective. But if we can, I'd like to even meet an even better. So in dosimetry, there's a saying that says like, don't just meet it, beat it. So try to do the best that you can. Now, if I only give this and then I just say, hey, don't just meet it, beat it. Well, like, how are they going to know exactly what's the most important thing to beat? Because sometimes if you try to do really well in one of these, it sacrifices how well you do in other things. So you can give guidance for the don't just meet it, beat it. I kind of mean, I want you to do this well. So just some food for thought as you're thinking about your own practice. It can be very helpful to have both a required objective and when it's helpful, a preferred objective and a template for every scenario that you encounter commonly, showing the targets that you want and showing the OARs that you want. You can see my PowerPoint slides again. Okay. So some other examples for prostate cancer, every case should have bladder, rectum, large bowel, small bowel, femoral heads, and penile bulb. For a post-mastectomy breast cancer, every case should have heart, trachea, left lung, right lung, lungs, spinal cord. And it's important that there's also space within your template to allow some flexibility. So a template should never be used as an absolute. It's a good starting point. But if a doctor wants to change or modify something, that should also be permitted and easy to do. Now, do I call it large bowel or do I call it bowel large? Do I call it left kidney or L kidney or kidney L or kidney left? So here's where we have a document called TG263, Task Group 263, and I'll put this in the chat. This is very helpful for just, you know what, we're not even gonna debate it, we're not even gonna argue about it. We're just gonna use what this document says. And if every center in the world does this, now we're gonna have everyone sort of uniformed. And it can be helpful for when you were making your templates, making sure that the same name is used every time so the planner is not confused. But I think the coolest use case for this is if in the future you want to do a review of how the quality has been at your center. There are things that can search through all the cases that you've done and look at specific OER names. And if every time you did that OER used the same name, then that search is going to be successful. So it's going to help you compile robust and useful data at your center if you use the same name every time. And then if you kind of just want to the best part about the report, it's definitely just the Excel sheet, which didn't copy the right way here, but it's on the slides. Okay. So how does contouring connect to treatment planning? So I talked a little bit already about setting up protocols, and there's some things that exist that can help you with setting up your protocols. And then I want to talk a little bit about clinical judgment. So I showed you an example of a protocol in the, okay, that sounds good, but like how can you can you show me how to do it? So what I would do is I would create a team at your center. It's going to be the protocol team. And the protocol team should definitely have a radiation oncologist, should definitely have a medical physicist or dosimetrist who works on the treatment planning. And sometimes even having an RTT could be helpful. And you may divide into sub teams where it's going to be, okay, we're in a breast team or head and neck team, or you could just work through one at a time. Okay, this week the protocol team's working on breast. Next week we're working on head and neck. You can make a calendar so you make sure that you get through everything that's important. And then for each site, we talked about writing down the targets that those plans have and the OERs, but also define what is the slice thickness that we're going to use in our CT scans. 3 mm slices, 2 mm, 1 mm. How should the immobilization of that patient be? And for image-guided radiotherapy, are we going to do cone beam CT or KV imaging or MV imaging or combination? And yeah, it takes some thought, but once you have this, it's going to save you so much time. It's going to make your clinic so much more efficient. And I would like, this is probably like one of the top things I would recommend any center to do. Like, yeah, it's just really good to set yourself up for success. So you may have heard of the Quantec guidelines, and this is something that planners really like referring to. Radiation oncologists also like referring to. The idea is, okay, there's all these different OARs, but what's the right dose constraint for me to use? And before these guidelines were published in 2010, this was a huge problem. Everyone was using different constraints. People didn't really know what was good or what was bad. And so there was a group of radiation oncologist specialists that decided, you know what, we need to do something for our field. And they had a conference in Michigan in about 2006 or 2007. And they decided, you know what, let's review all of the literature that's relevant to date for each of these different OARs and study that literature, see what toxicities happened and at what doses and how common was that. And they had a CNS team, they had a pediatrics team, breast team, etc. And and then they split off and they worked as a group, and then they came back like 3 years later and said, okay, that took a while, but this is what we got. And they published their summary into a nice table. And these are the Quantech guidelines. So it says for a specific OAR, getting this kind of treatment modality, the risk of vocal dysfunction, if the maximum dose was less than 66 to this OAR, was less than 20%. And that's how you interpret each of these different rows. So I've put that here. There's also links to it, but this is a good resource if you want a good starting point for what guidelines to use. Now, I'm going to finish this section on clinical judgment. So the most for patients that you're trying to cure, a marginal miss is worse than a tissue than a side effect or a toxicity. So in other words, the worst toxicity is a recurrence. So when you're trying to cure someone, it's very important that you prioritize covering your target. Now there might be some some OARs that you want to protect even more than the target, like the spinal cord, for instance. If you blast the spinal cord, then you can paralyze the patient. And some people could say, well, that's even worse than a tumor recurrence. So when you're comparing your goals, you do want to think about what's most important to achieve in general. Covering your target is most important when it's a curative case and should not be compromised to reduce the normal tissue risk. The other thing is that some of these guides, it's these are for pretty low rates of toxicity. So if you go a little bit above, it's not the end of the world. I will share one insight though. A lot of these normal tissue complication curves look sort of like, so if this is the risk for damage, so risk for damage, and then this is the dose. For a lot of things, the risk is pretty low, even as we're increasing the dose. But we get to a threshold where it starts to increase like this, and then it really increases before it plateaus. So it looks like an S. So a lot of these guidelines are sort of saying where does it really start to increase and like, okay, let's cut it off here. So it'll say like, try to keep the dose less than 65 gray. This is just an example. And if you do it, like, yeah, you have a nice low risk, less than 6%. But you don't know, and you have to be worried that even if I increase a little bit, let's say I increase this to 68. Well, what if my risk now has gone up so much? Maybe it's at 50%. So this is the reason why a lot of people really honor these recommendations. Because once you get outside of this green zone, it quickly can turn into a red zone, and you're not sure how quick. Okay, maybe I'll pause for questions if there are any.
We had one question about, you could share your thoughts on the Timmerman recommendations from 2021, 2022.
Oh yeah. So the Timmerman tables, those are great. If you're at a point in your practice where you're doing SBRT, that has some great general recommendations for 1 fraction SBRT, 3 fraction SBRT, 5 fraction SBRT, even 10 fraction or 15 fraction, not SBRT, but IMRT, where you're having steep dose gradients. So yeah, Timmerman tables are great. Any other questions?
How will we calculate the tolerance when there's different dose per fraction?
Mm. So some people have already done this, and then they make a protocol for their clinical trial that's testing that different dose per fraction. So what a lot of doctors will do is they'll be like, oh, let's look at the protocol for that study where they used that. And then they'll kind of copy the protocol and say, okay, this is what they did when they were doing 26 gray and 5 fractions for whole breast. So that's a fast forward. And that was a new dose per fraction. But how did the researchers come up with those dose constraints for those OERs? Someone at some point had to be original. And we get into what are known as BED, or biologic effective dose, and EQD2, equivalent dose in 2 gray fractions. And the BED and EQD2 calculations help you compare when you're using different dose per fraction. So like if before I was doing 60 gray and 30 fractions, what's the equivalent if I'm doing 15 fractions? And the answer depends on what is the alpha beta of the thing you're comparing. Generally, if it's a tumor, you'll use an alpha beta of 10. And if it's an OAR, you'll use an alpha beta of 3. Some tumors have a lower alpha beta, like breast has an alpha beta that's close to 4. Prostate has an alpha beta that's close to 3. So, so there's some nuance in this, and I'll tell you, the answer is not simple math. The you might think of it, oh, 30, but that's wrong. There's a formula for it that's complicated that we won't get into here. Okay, shall we move on? Good. So contour quality. I want to show a live demonstration about just how the quality of my contours actually could make a big difference. So I'm going to use this as an example. And what's interesting about this case is that the tumor is very close to the rectum. This can be a challenging case. And so I'm needing to basically decide what's tumor and what's rectum. And there's one problem here. Does anyone want to raise their hand or type in the chat maybe what the issue is? Brown is the rectum and red is the tumor.
We're getting some responses coming in. Tumisi said gas. Ayat said cross-border overlapping. The tumor is overlapping the rectum.
Yes.
The rectum is inside the tumor volume overlap. Yep.
Yes, exactly. Great. You are all correct. The overlap is a mistake. So if you do this, you are confusing your planner. You're telling your planner, hey, make sure the tumor gets a really high dose, and that's including this area of overlap. But you're also telling the planner, like, hey, make sure my rectum doesn't get high dose. But you're like, but you're telling me to put high dose in the rectum. So you've created a contradiction. This may not matter as much in 3D planning, but it's very good to develop good habits because when you get into IMRT treatment planning, this is going to be so important. And so you have to, as the person who's contouring, you have to be the one to decide and make that commitment. It's either tumor or it's rectum. It can't be both. And so I think the way I would edit this is I believe that this is concerning for tumor. And And then I actually would edit this just a little bit. But yeah, when you get to the level of detail that contouring matters, it can be this finessed. I know sometimes it's a challenge when there's a lot of cases and you have to work very fast, but try not to underestimate the importance of just how important it is when you're contouring the gross disease and the sensitive OARs that are right next to it. Okay, great. So that's a good illustration. We've learned from experience that even a 1 gray dose can make a difference. Radiation is all about precision. And oftentimes when we are making our guidelines and recommendations, we are practicing at the pinnacle of our specialty, where we're basically dancing on the tip of a dagger. If you go just a couple steps the wrong way in either direction, bad things can happen. So really honor some of the guidelines, the protocols, the doses that are used when, if you're giving a dose that hasn't been studied in a clinical trial, some may consider that to be experimental. Because although we may sort of use our reasoning of, oh, well, should be pretty good, you never know when one dose could make a difference, one gray of dose can make a difference. And here's another example where 3 gray dose made a really big difference. And this is for rectal cancer patients. And they found that basically, if you go to 50.4 gray, you'll always recommend surgery. But if you go to 54 gray, actually a decent number of patients never need surgery. This is a very sort of compelling study, but it is just sort of illustrating how even a small change in dose can make a big difference in examples. So precision is our responsibility. The doses are designed to be safe and effective. They're often right on the edge with little room for error. And yeah, so contouring is really important, guys.
Going back to the case example that you were doing, we had a great question of
Mhm.
how to deal with when there is tumor infiltration of an organ at risk and how that
Mhm.
impacts how you contour that border.
Oh, great question. If there's tumor infiltration, that means the tumor is now in that OAR. I would contour that part that's infiltrated as tumor. I'm not trying to rescue that part of the OAR because if I try to protect that part of the OAR, then I'm protecting the tumor that's there. So if a tumor is invading an OAR, you need to contour all of that tumor as GTV. And you will subtract that from the OAR contour. Great question. And those are really hard situations, by the way. Okay. So I apologize if I've kind of scared you out of your pants about contouring, but fear not, because there are guides for how to contour the right way. First principles. How do I know what to contour for the GTV? We've talked about imaging with the CT scan, but there can be additional information than your CT simulation scan. There may be a prior diagnostic CT scan that the patient had. Maybe it was higher quality or had contrast that helped you. So you can pull that in and register and fuse it with your simulation scan. Be wary that if that diagnostic CT scan was from 6 months ago, there's probably some stuff that's changed between now and then, and you generally want to trust your most recent imaging. MRI, PET scan, that can also help you with seeing the GTV really well. But there's some things that even imaging doesn't show very well that you can only see with the naked eye. Stuff like your physical exam, if it's a superficial lesion, endoscopy reports, if it's something that's maybe in the esophagus or in the rectum. or maybe somewhere in the head and neck sinuses. CTV. Sometimes imaging before the surgery can help you know, okay, where was the tumor, where there could there be microscopic disease. And so you'll bring in that preoperative imaging and you'll register and fuse that with your CT simulation scan. And you'll use both of those to help determine the CTV. Also, reading the surgical reports. It may say the tumor was in contact with the bladder. Now I know even after the surgery, even though the tumor doesn't look like it's close to the bladder because they took it out, I want to make sure I'm still covering that interface where it was touching the bladder. And that there's many other examples where the surgical report can give you clues about like where was the tumor before I did the operation and where am I hoping that my radiation oncologist will put dose. If your surgeons are not being very descriptive in their surgical reports, you can help educate them and say, hey, what you write, what you observe helps me do my job better, helps us treat the patient better. So please describe what was the tumor touching when you do your surgery report so I can know, since I'm giving them radiation, where I need to do the radiation. And in every scenario, we have contouring guidelines. Yay. So this contouring guidelines is going to integrate all of these things and help provide a roadmap for how to contour. Contouring guidelines are based on studies where we used a sort of a well-measured approach and we determined the outcomes. Early protocols were based off of concepts as well as experience from what we've learned from actually our surgical colleagues. So using rectal cancer as an example, when they would cut out the cancer and then look at it under a microscope, they could actually see where were their microscopic cells. And there were microscopic cancer cells within 2 centimeters of where the tumor was. And that 2 centimeters included most of the time all the microscopic cancer cells. So later on, ta-da, we use a 2 centimeter margin for our CTV based on the surgical principles. Other things, lymph node mapping and common patterns of failure. So the head and neck surgery, they will dissect parts of the neck when they're doing surgery and they'll look at those and they'll see which of these lymph nodes were involved. And this is how we learn sort of the drainage pathways. What goes to level 2 versus a level 3 lymph node? What goes to level 5 in the posterior neck, etc. And so these surgical experiences where they map the lymph nodes now help us as radiation oncology professionals know if they didn't do surgery, where should I cover? Which lymph node should I do? And we do this all the time for breast cancer when we're doing the regional nodes and treating the axillary level 1, 2, and 3 in the supraclavicular field, and now even the internal mammary nodes in some cases. And today, these contouring guidelines synthesize all the most up-to-date understanding and protocols, and they should be used, especially when early in adapting your 3D practice. So we have our favorite contouring guideline resource. Everyone should check this out if you are involved in contouring. This is econtour.org.
I do have mine up. I don't know if you wanted to, I could share
Yeah,
my screen and you could take control if you
sure.
like.
Yeah, or yeah, I'll hand the mic over to Mike. No, that's kind of a funny pun. So yeah, Mike, do you want to show the class what the eContour website is like? And 60% of you are already familiar with it, which is great. But we want 100%.
Yes, absolutely. So eContour is a really excellent resource where you can search by different disease sites, and they have examples of what a consensus recommended contour would look like based on experts who practice in this disease site. So for example, for head and neck, you can see here cutaneous squamous cell carcinoma, larynx, nasopharynx, oral cavity. But you can see this for all the different disease sites here. Sometimes it references a specific study that they used. So here, for example, for this stage 2 cervical cancer, they referenced Embrace 2. And so you can see here they describe very clearly how they made their contours. And they also have clinical pearls that the experts who designed these contours thought were important in how they were defining their volumes. And so the cases are very useful and far-reaching. You can see different stages, different patient populations. You can see hypofractionation versus conventional fractionation. And so this is easy to register for. So if you just go to econtour.org, you give them your email, make a password, and you'll have access to all of this. They also have another helpful resource, which is consolidated guidelines that have been published about contouring. And so this will, if you have a particular question about a particular case, instead of needing to search the internet or Google to find a contouring guideline that is relevant, this will potentially likely have what you need because they've consolidated many of the most relevant and largest consensus guidelines for most disease sites. Was there anything else you wanted to share about eContour, Ben?
That was a great overview, Michael. Thank you. Yeah, if you could open up maybe a head and neck case, the way I would recommend kind of starting off with, if it's your first time contouring something, is to find an e-contour case that matches the specific clinical scenario for your patient. And then one structure at a time, I would show it. And then on my other computer, so like if you have two screens side by side, as you contour on your real case, have this open and then scroll down one slice and work on the next slice and use it as a guide so that each slice you can make sure you're sort of using that you're matching it. And the patient's gonna have the same anatomical structures that are used as boundaries. It might be slightly different size or shape, but you want to make sure that you're using the same boundaries as what they're using. And it may take a couple hours for your first case, but it gets better. It gets better. And with experience, you can get down to some pretty fast contouring.
Yeah, so just briefly showing you this example, this is a T3N0 larynx, and so they contoured the GTV in purple here. I can maybe just start from that. So this is where, based on their physical exam, maybe they did a scope, maybe they had a PET scan, and so this is where they thought the tumor was. So then they made their high dose CTV 5 millimeters beyond it and edited it based on how they thought this could spread. They included the whole larynx, it looks like, in their intermediate dose. And then they also show you all of the lymph node regions here that they thought they needed to include. And then they also show all the organs at risk that are relevant in the head and neck. You can see this is a long list here, but it is helpful to have all those examples as you go through contouring.
Great, thank you, Michael. So just a few more resources I want to empower you with, equip you with. So there's the ProKnow Systems Quality Contouring, which I mentioned, lets you practice, then you get feedback, then you can practice again, get more feedback, and you can improve your score. So yeah, that one's really good. There are these NRG, National Research Group here in the US. oncology contouring atlases. And I will, let's see, put this in the chat also. So this is great. It lets you download PDFs, which it's a little bit like less fancy version of eContour, but also can give you step-by-step or slice-by-slice guides for contouring for different disease sites. And then here's some select resources for radiation oncologists and other professionals for the RCC YouTube channel. Of course, everyone is welcome to visit that. You can subscribe if you want to get notifications whenever we do a new video. If you click on popular, these are actually some of the videos that I guess the crowd has found to be the most helpful. So I really recommend this one, head and neck OAR contouring, a walkthrough. Someone asked about, is there any resource that actually like sort of trains you how to contour, like talks you through it? So I'd really recommend this one. You'll learn a lot. And the other one is breast contouring for regional nodes, which may be a common scenario that you experience at your center. For those that here who are already doing 3D and are doing IMRT, and if you have Eclipse, these are two videos that are very good for mastering VMAT planning. There are also several other links which I'll have in the slides. These are kind of some of the best. So I encourage you to explore these. There's one that's actually it's really fun. It's the RADONC tables, and actually I need to update the URL for this. I'll fix that. But it's basically if you're ever wondering like what studies exist that I should know about as a physician, this has a summary of like all the major phase 2 and phase 3 studies. And it's actually also available as an app. So you can download the app from the App Store. It's called RADONC Tables. And then the actual spreadsheet looks like this. So you can go by disease site for ductal carcinoma in situ. These are all the main studies. For early stage breast, these are all the main studies. If it's yellow, it means it was a really important one, and it just provides a summary. So that's an excellent resource, and special thanks to everyone who helps maintain the RADONC tables. And then for treatment planning, I really recommend this dosapedia.com. Dosapedia is a cool website which has lots of things made by dosimetrists who went through their own struggles of learning treatment planning, and then they want to make it easier for other people in the future. So lots of short video tutorials on all sorts of different planning. They also have some good memes on the website. For radiation oncology anatomy, there's a group in India that set up this thing called Avero Project, which is a series of modules specifically for radiation oncology professionals. And then there are also these other sort of anatomy websites. For medical physicists, and even for those who want to learn more about medical physics, I highly recommend this medical physics primer videos. These are amazing. Everyone in the US basically uses this when they're studying for their medical physics board exams. And there's also something that has recently been released by the Medical Physicists for World Benefit. It's called the Open Syllabus. It has lots of links to existing resources as well. Last but not least, it's the RCC self-learning resources. I mean, I should probably come up with a better name for this, but it's something that describes what it is. And I'll put that in the chat as well for you. But this has a summary of kind of all of the best resources, many which have been in this PowerPoint, but just put in an Excel sheet for you that's simplified. And most of the resources put here are free, but there are also some resources that you can pay for if you find it helpful. Okay, so last Zoom poll. This question might look very familiar. but which of the following are you familiar with? Meaning you could describe what it is to a friend. Go ahead and take 8 or 10 seconds to fill this out, and we'll be finishing up very shortly. This is super helpful and also very interesting. Okay, good. We have about 70 people who have filled it out. Take a moment to fill it out if you haven't yet. Mark all that apply. Okay, get 5 more seconds. 4, 3, 2, 1. Okay, I'm gonna end the poll. Great. And yeah, so you can see the results here. This is interesting. Seems that we've had some improvements in awareness. And now, yeah, this is great. Okay, thank you for filling this out. So putting everything together, guys, we know that contouring is important. We stressed that a lot today. Planning is really important, and we're going to get more into that. Physics and QA is really important, and then daily positioning is important. As a team, you're only as strong as your weakest link. So everyone needs to be trained and educated to do their job well. And one thing that's really going to help that is team communication and things like this course where everyone is hearing and seeing the same thing. So there are documents and checklists that could be helpful. I showed some protocols. There's going to be more that's introduced in this part 2 of the course. And let's, yeah, work together, learn from each other, and make cancer care better in all of our countries. So with that, I want to thank you for your time. Thank you for your great questions.